very little. A lot of detail on the face tends to mean that the person puts a lot of focus on appearances. Now that may be very appropriate for you as an individual. You may want to continue that, or you may want to change it again. You may want to look at how much energy are you putting into how you look, and is that really where you want to spend so much of your energy? If the answer is yes, then that's fine and good. I lived for 11 and a half years in Texas. Texas women always overdrew the faces, not always, but a high percentage of the time. And that was appropriate for the culture. And is there no face? Did I leave off all face details? If so, does that mean that I see myself as faceless, as unimportant, as having no identity? Again, just questions for us to ask ourselves. Look at the shoulders. Are the shoulders in this group, I would expect lots of big shoulders. Lots of big shoulders. Especially lots of big left shoulders. Okay? Lots of responsibility for other people's feelings. Okay? So look at, left, right, look at the shoulders. This is real important for my patients, my patients who, but health professionals tend to draw themselves with big heads and big shoulders. We think a lot, take on a lot of responsibility, and tend to have very poorly drawn hands. Okay? Hands tend to be associated with our perceived ability to get our needs met. See, most of us work out of the dynamic of, if I do enough good things for other people, surely somebody will help take care of my needs. So my hands are usually pretty poorly drawn. Drawings, I try to draw them better, but it doesn't seem to work. So the unconscious comes through even when you try to compensate. And if you're a graduate student, you have a high probability of not having feet. Feet tend to be associated with groundedness. As a graduate student, usually I'm trying to figure out what the professor wants me to believe, and that's what I'm going to believe. So it doesn't make a lot of sense to put a lot of energy into drawing feet. Or being very grounded. That's going to cause me difficulty when my beliefs aren't compatible with my professor's beliefs. And especially around dissertation time, the feet really disappear, according to some of the people who have done these studies. For my patients, when they don't have feet on their drawings, to me the question is it important for me to put more emphasis on the development of my core beliefs? Okay. Then looking at some of the obvious things, the relative size and power of the cancer. As you look at your drawing, is your cancer obvious? Does it stand out, or is it kind of, you have to look for it? What looks more powerful in your drawing? The way you drew the cancer, or the way you drew your body's healing mechanisms? And how did you draw treatment? Many of my patients leave the healing system completely out of their drawing. That translates into having very, very little belief in their body's ability to heal itself. And so work on their self-concept becomes very, very important. And you don't do that by saying, oh, you don't have any white blood cells in your drawing. Because the person is afraid you're going to tell them that as a result of looking at their drawing, they're going to die anyway. That's one of the biggest fears around the drawing. So it's important to be delicate with people, because I know every time I do a drawing, every time I've done a drawing in any sort of personal work, I feel very exposed and vulnerable. And I would imagine many of you are feeling some of that now. And so I think it's important in dealing with patients to realize that and to help them be gentle with themselves and each other around looking at this, what you're reading into this drawing. And after all, it is just a drawing. Then looking at the color. before I go to colors. Wavy lines tend to be associated with fear. Sharp projections tend to be associated with anger and abrasiveness. And if things kind of cover other things over to where you can't quite see what's what, that tends to be associated with denial and confusion and fear. Now the colors, green tends to be associated with health, healing, and new growth. Blue tends to be associated with power, particularly masculine power. Whereas white tends to be associated with power, but more feminine power. Brown tends to be associated with logic and reason, earthiness. Yellow tends to be associated with energy and the intellect. Orange tends to be associated with change and danger. Gray tends to be associated with change and transformation. Pink tends to be associated with health and healing. Purple tends to be associated with specialness and spirituality. Red tends to be associated with energy, vitality, and anger. Black is an intriguing color. It tends to be associated, of course, with the unknown and fear. But it's also associated with wisdom and knowledge and power. The black robes of the clergy, the black robes of the judge, black robes of academic attire, black robes of the witch. It's a very powerful color. So then what I would ask you to do is to write down one thing that you're pleased about yourself that you discovered as a result of doing this drawing. And one thing that you discovered that you would like to change about yourself or your beliefs that you discovered as a result of this exercise. And then to take 3 minutes and communicate that to the person that's sitting next to you. And it's better if you don't speak the same language. So if you'll take 3 minutes and just communicate whatever you want to communicate about this exercise to the person next to you. Again, to kind of increase your sense of vulnerability and take care of yourself around that. Very important work at looking at beliefs. In general now, what we've done is the patients came in imagining themselves getting well 3 times a day, because that seems to be one of the most effective practice schedules. And I had backed off that somewhat over the years until I got back into more around learning theory and cognitive behavioral therapy, and I've gone back to where I started 20 years ago, suggesting that they practice their new beliefs 10 to 15 minutes 3 times a day. Now with some people, it's better that they practice for 15 seconds 3 times a day, or 15 seconds 10 times a day, because that's all they can hold the focus of their attention. So it needs to be modified and tailored very specifically, just like some people most effectively practice the piano for 15 seconds at a time. There will come a time when that will change, but you're dealing with what works best now. And again, looking at where they are with their beliefs, where they want them to change, and the work is now pretty well set. So what I'll do is, before we take a break, look at 1 or 2 questions that kind of touch the tip of the iceberg of the questions that might be coming up for you now. So who has a question that you'd like to ask? No, this is a very good sign. Yes.
In your drawing interpretation statement, you didn't say anything about the social network. I wonder if the drawings ever encouraged to include the family members who assess the social network at the same time.
The question has to do with doing drawings to evaluate the social system. I don't do that. I've done it before. Family therapy, that gets into those sorts of issues, and no, and it certainly is a very rich area and has application. But we don't do that. I have done it. It has great value. Well, it looks like everybody's ready for a break, so we'll come back in 15 minutes and field a few more questions and then start working on the concept of the and to carte blanche do the things that have been done are, again, similar to other scare tactics to move from point A to point B. And I went to the cigarette companies years ago. I thought they would be excited about this information. Well, they ignored it, and it's some of the most beautiful work in emotions and cancer that's ever been done by Dr. Kissen, and is published in many responsible places. But I'll say something, because Kissen has had such an impact on my own life, even though I didn't have the opportunity to meet him. He was dead before I even knew that he existed. He was quite a prominent and excellent physician in Scotland. And his life work was really around the emotions and cancer, particularly lung cancer. And he did beautiful studies. And he was a very good friend of my mentor, Larry LaShawn. And so I was curious why he died so young. And so I went to Larry and I said, Larry, why did Kissen die? He died at early age. There's reasons, whether or not we know them, but I figured Larry would know. And he said, yes, that when they did a big symposium, there were 2 very major international symposia done in the United States on psychophysiological aspects of cancer, but held by the New York Academy of Sciences. One was I think it was 1966, and the other one was 1969. And Kissen presented his work in 1966. really his life's work. And he was so criticized by his professional colleagues at home that he died of a heart attack. And Larry said he clearly died of a broken heart around the rejection from his colleagues, because it was a very excellent position. So in 1969, when they held the subsequent conference, they dedicated it to kissing. And so I have very strong feelings about all of this work, and about our irresponsible acts as physicians in stopping good work that's been done. So I'll stop preaching on that. Any other question before we, yes?
I just wanted to mention that I felt uncomfortable doing the drawing because, again, it felt like imaging something negative into me, whereas I felt I would rather image something negative going out of me. So, for that reason, I didn't do it. I was concerned also about where people put the cancer and why, with the family background, and to protect themselves against having that image of what family inheritance passed along. So it might be interesting for them to protect themselves from some family illness.
I will comment on your first comment of feeling uncomfortable about doing the drawing. This is very common, especially in health professionals. It's common in a lot. It's a common problem, and I appreciate your communicating this. And part of the difficulty has to do, again, with the belief of looking at why are you doing it? What is the purpose here? And again, the purpose of the exercise was to, from my standpoint, and was to identify some of your healthy and unhealthy beliefs about cancer. So that's the purpose of it. And that's important to stay in touch with. Okay, that's why we're doing it. But then we get into magical thinking about the power of our imagination. We exaggerate that in our own mind. Now, then those beliefs are going to play a role in my ability to communicate with my patients, and so that then becomes a very important area to explore. And so thank you for being willing to tell me that. Okay, let's go on to, here's a question that was written out that I will respond to. What to do as a psychotherapist when not the patient but the spouse asks for help, because the patient believes in psychological factors and the spouse does not. Well, to me, you can only work with people who are willing. Do you want to identify yourself? Who asked? Okay. You can only work with the people who are willing to work with you. And in that case, just working with the person on how they can be more effective support in that way. How can they both take care of themselves and be as supportive as they can be of their spouse, and showing them how to responsibly put options in front of their spouse without attempting to coerce them into doing something that they want to do. So there's a lot of work to be done with the spouse, and none with the patient who doesn't really want to work.
Not yet, I hope. That's my hope, that my husband can convince me to
Yeah. Yes. And I think this brings up a very important issue of being attached to outcomes, okay, as therapists. Is there a great temptation in this work that I get to where I want my patients to get well, okay? And I want them to make certain changes that I know would be good for them to make. And I start working a lot harder than the patient. And I start putting a lot of pressure on the patient to get well. Okay? And that is not good for me, and it's not good for the patient. So it becomes important for us to find our own level of balance. It's good for me for people to get well when they need not die. That's good for the planet. At the same time, watching my, where is my motivation for looking at the intensity of the emotion and the dynamic? So it's an important area. There's a lot of work to be done, and it's important to allow people to die the way they want to die, and to support them in their supporting them into getting well our way. Okay, and that also is very, very important.
The background is the husband is my patient.
Uh-huh.
He came to me and
Right.
told about
Yes.
his
Mhm.
wife.
Right. Yeah. You're welcome. And it's very important and appropriate for him to put information in front of her and to confront her on these issues and to help him find balance in doing that. I've got this right now with my father-in-law, who I'm very close to. And I talked to him one night because he's got slow-growing tumors that he's growing fast. Okay? And that causes me great concern because I'm very close to him. And I sat down and I told him. And he made it very clear, non-verbally, that he wasn't interested. And as a son-in-law, that's really, even as close as we are, that is and was as far as was appropriate for me to go. My body told me that a whole lot more was going on with me because after a 2-hour conversation and I got up, I could barely walk. My ankle was bothering me so much. However, for his daughter, my wife, it's more appropriate for her to confront him in other ways than it is for me, because that, again, and it's important that we do those things, but we have to do them within our own conscience, with a lot of thought and prayer, so that we don't do things that create barriers in the family, so that it's clear that what's being communicated is love and concern, and these are delicate issues and important issues, and they're important in my life today. Well, okay, let's look at Hope, Trust, Purpose, Inner Guide, that complex. As I indicated before, it's important to appreciate that hope is a belief. Okay? Hope, we all know, is important in health. Hope is a belief. It is the belief that desirable things are obtainable, not that desirable things will be obtained. And it is important to support people in maintaining hope. The opposite of hope is hopelessness. Now, hopelessness is absolute. That means there is no hope. Okay? There is no possibility of a desirable thing happening. Almost never is hopelessness appropriate. Okay? Almost never is hopelessness appropriate. However, that has been one of the predominant ways of communicating in the American oncologic or cancer community. Don't get your hopes up is a common statement made by oncologists. And a patient may be doing better and they say, well, don't think this means that you're going to get well. That is very undesirable behavior. It is very unhealthy. I'm learning to use kinder words than I have before around such issues. But those are the most appropriate words. These are unhealthy and undesirable behaviors. Because what really is the physician is doing is attempting to force his or her beliefs onto the patient, telling them what to believe. And what they're really saying as a physician is, I don't want to get my hopes up, because as a physician I have gotten my hopes up many times over patients like you, and they've all died, and I don't want to get my hopes up again because I don't know how to deal with the pain of your death. And this is the basic problem. But it's a basic problem that's not being addressed in the United States. It's not being addressed in the education of medical students or oncologists. I can see it not being addressed in medical students. I have no reasonable way of understanding why it is so difficult to get these concepts to be taught to oncologists who are being trained to deal with people who are dying and are not being trained on how to deal with death. I have not seen health figures on oncologists. My guess is they're going to be atrocious when we see them. Because we've given this group of professionals a job to do, a very difficult job to do, and not given them any tools for how to deal with death, when that's what their work is. And so